Welcome everyone this evening. I'd like to acknowledge that we're meeting on Ngunnawal country today, and I pay my respects to the Ngunnawal people as the traditional custodians of the land in which we're meeting, and also pay my respects to elders past and present. I'd also like to extend that respect to any First Nations people joining us this evening, and also other Aboriginal people with connections to the land in which we're meeting. So thank you for joining us this evening. This is the last of 7 webinars for end of life in primary care. Just to recap, you can see the other sessions that we have provided over the last 7 weeks on a Tuesday evening. We strategically did this in leading up to the introduction of voluntary assisted dying in ACT, which commenced yesterday. If you've registered for the workshop this evening, you will have access to the recording of all the other sessions. So please know that they will be all posted onto the CHN YouTube channel over the next few weeks, and you will have access to review those as well. So I'd like to welcome for our 7th session, nurse practitioner Kate Reid. Kate agreed to this many months ago, but probably didn't quite anticipate the busyness of this week, and particularly yesterday and today. So we're very grateful for Kate to join us this evening. So thanks, Kate. And handing over to you to talk to us about voluntary assisted dying in ACT, the intersection with palliative care, and your experiences that you've learned from other states and jurisdictions. So thank you. I'm going to stop sharing my screen and I'll hand over to you, Kate.
Okay.
Stop sharing. Has my screen gone?
Yeah, I think I started sharing mine, but
okay. Yeah. All right. Great. So at the moment it's black.
Loading. Okay. Oops, it says, oops, something went wrong. Is everything okay? No, I just stop sharing and restart sharing.
Okay. Thank you.
IT. I think that's working now. Or it's coming in slowly. Yep, fabulous. Hi, everyone. My name's Kate Reid. I'm Palliative Care Nurse Practitioner as my clinical role, and I'm currently working as the Director within the Implementation Task Force for Voluntary Assisted Dying at the Health and Community Services Directorate. Thank you very much, Roz and team, for inviting me tonight to talk to you guys in these webinar series, which has been a fantastic initiative of the CHN. So it's really great to see this kind of work going on in our sector, and the type of education that we are able to deliver. And yes, it's certainly been a big couple of days, and hopefully there's a few of you here who haven't seen any of my talks and aren't going to be too bored by the same thing. But hopefully I also we've hopefully got some time for some questions. I didn't check in with Roz about this prior, but Roz, are we going to just sort of monitor the chat and we'll do some questions afterwards? Great. Okay, so voluntary assisted dying. So in the ACT, this is the Voluntary Assisted Dying Act of 2024. It was passed in June of last year, and it's supported by the Voluntary Assisted Dying regulations. Now, this is currently, as of yesterday, an end-of-life option alongside palliative care for eligible people in the ACT. So voluntary assisted dying in itself, when I talk about it, it probably sounds a bit strange because I never use the words VAD or VAD. And mostly that is for consumer-facing discussions. But that's really about to explain that this is a voluntary legal process for those who are dying that meet strict eligibility criteria to request a medically assisted death. The words are really important when we're talking about voluntary assisted dying and what that the actual act of a voluntary assisted dying process and how important that is. So there are mechanisms to ensure that voluntary assisted dying is only accessible by those who are eligible, and there's protections for against coercion and exploitation. And there are also obligations and protections for health professionals, practitioners, and facilities so that they won't hinder access, but they can also balance that with their own conscientious objections if they have any. So, like I mentioned before, voluntary assisted dying is being implemented alongside palliative care services. The two go hand in hand. It is an option of end of life care, it is not an alternative. So we are the first territory, but all the states have gone before us. And so there is a private members bill that's currently in the Northern Territory that they're considering. And we are definitely being able to really get a lot of help from the other jurisdictions. It's always good to be one of the last ones, to be honest, because you get a lot of, you learn a lot from other people's lessons, and they've been incredibly generous. So voluntary assisted dying in the ACT has some really progressive parts of it. There is no time frame to death, and I will explain that in a little bit more. There's no minimum numbers of days between any of the steps in the process. There's no cooling off periods, no waiting periods. Things logistically have to happen in sequence, and we all know that getting things happening in a health area can be quite problematic, just to get the people all organised and just all the things that go with it. But in saying that, as per the legislation, someone could technically start a voluntary assisted dying process in the morning and finish it in that same night. Nurse practitioners can act as coordinating consulting practitioners in RA. So, and there are offences for health professionals, but also care facilities that hinder access to voluntary assisted dying. So the eligibility criteria, and this is where the rubber really hits the road for voluntary assisted dying in the ACT. You have to be over 18, same as every other state. Every other state. You have to have lived in the ACT for the past 12 months, or have a substantial connection to the ACT that would allow you to apply for a residency exemption. You have to be diagnosed with a condition or conditions that are progressive and advanced and expected to cause death. This is where the time frame to death changes, because somewhere like New South Wales, it's 6 months with a malignancy or cancer diagnosis, and it's 12 months for a neurodegenerative diagnosis. We don't have that here. We have advanced and progressive. So we're really looking at end of life, and it needs to be causing intolerable suffering for that person, however that might be interpreted for that person, to work through with their voluntary assisted dying practitioner, because one person's suffering is not necessarily another person's suffering. Then they also must have decision-making capacity in relation to voluntary assisted dying, not necessarily getting a share portfolio or buying a house, but medical decision-making in relation to voluntary assisted dying from the beginning to the end and all the bits in between. And throughout, their request must be voluntary, and it must be made without any coercion. So there are key safeguards that really make sure that this is a safe and well thought out act. No one can request voluntary assisted dying on behalf of another. So you might find that someone will call or will speak to a practitioner, a carer. That won't be good enough. It needs to be the person. And of course, if there's communication difficulties, it's the way they would normally communicate their wishes. They have to be able to do it themselves. It is a criminal offence for someone to induce someone to have voluntary assisted dying or to revoke it as well. You can't stop someone from having voluntary assisted dying without there being risking a criminal offence. As we said before, it has to be voluntary and free from coercion, and the person must have that decision-making capacity. A person will be assessed for eligibility by 2 independent authorised practitioners. Now, that And I will go through the process in just a moment. The coordinating practitioner does the bulk of the work and does that first assessment. And then there's a completely secondary, and I'm just going to let my dog out before he barks. Just one sec. Dash, out. Sorry. Oh, sorry. Oh, Dash, go. Sorry. I am so sorry. This is what happens when you're working from home. It's normally a child, but that time was a dog. So there's back to my 2 independent authorized practitioners. They're looking at eligibility. And so if someone is found to be eligible, then the second person will do, the next voluntary assisted dying practitioner will do the independent review of that. If there's a little bit of unsureness about this, or they're just there's a few questions being asked, they can go to another person for an expert opinion. It doesn't have to be a voluntary assisted dying practitioner. It just might be someone who's involved in that person's healthcare. It might be their social worker, could be their neurologist, could be their oncologist, could be anyone who happens to be part of or their GP, because they usually know them best. So that might be who they reach out to. A person can also pause or stop the process at any time. Once they're in, they're not committed to it. So stopping it would mean they'd have to restart it from the very beginning. But if they were to pause because of something that might have happened, it might even be that their cognition's fluctuating, and the practitioner might want to come back and do another assessment on another day just to see if they can get them at their best possible time, or wait till they've had another assessment by a third practitioner just to say, yes, they're okay, they've got decision-making capacity if there's a concern. So that pause can happen. It might be that someone goes into hospital and then they come back out again. If they've missed their appointment, doesn't mean they have to start again. But it is important to know that if someone's been made eligible in New South Wales, that doesn't mean they wanted to go down a voluntary assisted dying process in the ACT, they would have to start that again. They would need to start in the ACT. Nothing for that New South Wales one carries forward, and nothing of the ACT one carries over. So that's really important to know. There's also, the person must make 3 separate requests for voluntary assisted dying. The first request is a verbal. That's just literally like, I want to explore voluntary assisted dying, or can you tell me about voluntary assisted dying? I would like to know more. That might be considered the formal first request. Second request is a written request. However, that person can write. If they can't write, they can have an agent do it on their behalf, and that does require to be witnessed. And then there's a final request, which is also a verbal request. Practitioners must also be authorised to be voluntary to give or participate in voluntary assisted dying services. And if they're acting responsibly and reasonably under the Act, they are not criminally or civilly liable for anything that they are doing under that Act. All health professionals and facilities can refuse to participate in voluntary assisted dying, or even part of it. It might just be part that they don't want to be involved in, but there is minimal obligations, and we'll talk about those in a moment too, because it's essential that access to voluntary assisted dying is not obstructed. Also, voluntary assisted dying under the Voluntary Assisted Dying Act of the ACT is not suicide. It states that very, very clearly. And the reason why I bring this up is because there are certain parts of the voluntary assisted dying process that's discussed or has to be educated to the person, to their loved ones, around the specifics of taking the substance, how to take it, and what that substance is, that cannot be shared on what's called a carriage service, which is literally telephone, teleconference, email, this kind of thing. I could never go into detail with you about how a voluntary assisted dying substance is actually taken. So that is because of the Commonwealth Criminal Code, which supersedes any territory or state act. And so this is only around what that could be considered as being suicide-related material. So we're back to hard copy, which is a very strange place to be. So everyone asks about dementia and loss of capacity. So I like to talk about this a bit early. So dementia on its own is very unlikely to make a person eligible. So even though we know that dementia is a life-limiting illness, when it is at the time that it is progressive and advanced, the person would no longer have decision-making capacity in relation to voluntary assisted dying, and therefore they would be found to be ineligible. It may be that someone would be seeking voluntary assisted dying for another purpose, let's say metastatic lung cancer. That is progressive and advanced, and they are found eligible for that condition, and they may have a background of dementia that is like osteoarthritis or type 2 diabetes that's sitting in their background chronic comorbidities that is not having an effect on them and is not at the stage where there's any cognitive impairment and therefore not affecting the eligibility criteria. So if that makes, I'm very happy to take questions on that if need be, because I know that this is one of the concerns that's being raised again and again in the community, and we are going to be looking at this in more detail into the future. But for right now, it is certainly what is really important is that the eligibility criteria, no matter what's going on over here, is being met, and so that's what's essential, and that this. In the Act, they also talk about mental disorders or mental health disorders or mental illness or disabilities as well. And it's the same sort of thing. And really around disability that only impairs communication, learning, or mobility, resulting in the need for support services, will not make a person eligible for voluntary assisted dying. And that's really clear and important to mention so that vulnerable people aren't at risk of being exploited in any way. So authorised practitioners, to become authorised, that people have to a medical practitioner, nurse practitioner, or a registered nurse, and will have to submit an online application. They have to have strong qualifications and experience requirements that they meet, and complete the mandatory training done at the Health and Community Services Directorate. There are 3 roles that occur within the voluntary assisted dying process. There's a coordinating practitioner who does the bulk of the work. That's probably the heftiest role. The consulting practitioner does that second independent assessment, and then sort of disappears from the process once that's done. And then we've got the administrating practitioner. That could be a third person, or it could be the coordinating practitioner. It could even be the consulting practitioner, to be honest. It's a role in that the voluntary assisted dying process. So just to highlight this, because I think we have a couple of medical practitioners and maybe a nurse practitioner, but definitely some RNs on the webinar tonight. So medical practitioners can become authorised coordinating or consulting practitioners. A nurse practitioner could also become an authorised coordinating or consulting practitioner. In the one process, the voluntary assisted dying process, it can't be both nurse practitioners, authorised voluntary assisted dying practitioners who are nurse practitioners who are doing both the independent eligibility consultings. It has to be either 2 doctors or a doctor and a nurse practitioner. The medical practitioner and the nurse practitioners can also be administrating practitioner, and so can registered nurses. And so they all do the same application process. There's slightly different criteria, as you can see on the slides, as for who meets mandatory requirements. But they all do exactly the same education as well, and they're all involved in the supportive community of practice that we have already started, and we've had 3 meetings for our authorised practitioners to ensure that they've got a collegial and a supportive peer mentorship for each other, and also an avenue for further education, which has been a really great thing for our authorised practitioners. So this is all supported by the Voluntary Assisted Dying Care Navigator Service, which is located at Canberra Hospital. It is a point of contact for the whole of the community, all of the practitioners, and all of the health professionals. So, it's kind of your phone a friend, 5124 888, that's the number that people call for if they've got any concerns at all. And so if you're ever thinking, oh, I need more information, yes, there's quite a lot of information on our website, and there will be more information that's coming on health pathways as well for those who are involved in health pathways. But also giving the Care Navigator service a call is really important too. And so this is co-located with the only pharmacy service in the ACT that is allowed to supply or dispense and dispose of the voluntary assisted dying substance. And so this won't be happening in community pharmacies. People will be told that they're not allowed to just take their substances to community pharmacies, and we've been working with the community pharmacy to try and make sure that they have a really good understanding of what's going on as well. So there is just for interest's sake, there's 3 different ways that voluntary assisted dying practitioners are being employed. One is through the Care Navigator service at Canberra Hospital, or the pharmacy service that have authorised practitioners, through the Care Navigator service. The other one is through the Health and Community Services Directorate, where you can either be reimbursed for administrative times, because each part of the process has very clear points of administrative times where you have to do paperwork that is submitted to our oversight board. And then we've got option 2, which is contracted services. So someone might work like a day a week or a day a fortnight with and see voluntary assisted dying patients. And all of those appointments are coordinated by the Care Navigator service. So just to take us back away from the workforcey, how we built those authorised practitioners. And by the way, we have 29 authorised practitioners in the ACT, which is a really fabulous mix of doctors, GPs, and specialists, and as well as nurse practitioners and registered nurses. So it's a true multidisciplinary team. So with raising voluntary assisted dying, we don't have the really difficult time that Victoria's had with the gag, where the health practitioners can't talk about voluntary assisted dying. But certain health professionals certainly do have obligations under the Act if they're going to bring it up. So medical practitioners and nurse practitioners, so those with the expertise to be able to talk about treatment and palliative care, must do so and ensure that that person knows about their options if they're going to bring up voluntary assisted dying with them. If those medical practitioners or nurse practitioners don't know, have that expertise, or any other registered AHPRA health professional, or thirdly, the social workers, speech pathologists, and counsellors who are non-regulated, but they were isolated in the Act, if they were wanted to bring up voluntary assisted dying with a person, they would first of all, of course, need to know or reasonably believe they'll be eligible, rather than just bring it up. And then make reasonable steps to ensure the person knows how to get that information from either a medical practitioner or a nurse practitioner with the expertise, or you phone a friend, calling the Care Navigator service, which always is the best go-to, because they could find someone who could do that for you. So health professionals, like I mentioned before, can absolutely refuse to take part in all or some of the voluntary assisted dying process. It might even be that an authorised practitioner refuses to accept a first request. It might be because they've got too many people on their books. Most of our authorised practitioners are working that as a second job. So they may be limited as to how many people they can coordinate for. Or it might be that, or they know they're going on a holiday, so they don't want to take on another patient, or they might want, or there's other health professionals who may not want to be involved in every part of the process. But there are also people who may have a conscientious objection to be involved in any of the process. And that's absolutely fine, and that is their right. What they must do, though, is say, I can't help you. They don't have to say why. That is entirely their own business. but they must provide the written contact details of the Voluntary Assisted Dying Care Navigator service within 2 business days under the Act, or face maybe looking at an offence against the Act. What we have done at the Directorate is provided a guidance fact sheet, which is like a 2-pager, like a back and front, which people can easily download and print and give off to someone, and that would fix that. If it's a conscientious objector, we have feedback has been from our health professionals that they don't want to give that much detail. So they're more inclined to give the Voluntary Assisted Dying Care Navigator service contact card, which literally has the name, the phone number, and the email. And so they're just giving that. So that can be downloaded too, and just those contact cards given. So care facilities also have obligations under the Act, and they're quite stringent, and they should be in place as of yesterday, that they must have a policy stating their involvement, how much involvement they're going to have with voluntary assisted dying services, and how they're going to assure that there is reasonable access for their residents to have access to the relevant person for voluntary assisted dying. Or if they're not going to be involved, how are they going to, they're going to have that, be able to have people come on site? If they're not going to do that, how are they going to transfer people out for appointments and make sure they're coming back in? Or are they going to have a chat to them about maybe transferring to another another facility where they are doing voluntary assisted dying? Or they can talk to the Care Navigator service and try and work out other options. We've also heard from other jurisdictions, things like patients in residential aged care, where they've done all of the appointments. That's been absolutely fine, but they haven't been able to safely store the substance. And so that person is actually, and the family have chosen that though they couldn't care for the person long-term at home, they got them home for the purposes of voluntary assisted dying, and they died in their home after a couple of hours. And so you can see how that might be something that it's just a matter of, it's all about the conversation. How are we going to best meet this person's needs and what they best want for their end of life? So the process itself is a 10-step process. So we've got the first request, and this is when a voluntary assisted dying practitioner would accept that first request. It's that first of that 3 requests that we talked about. It's a verbal. If this first request is made to a person who is not a voluntary assisted dying practitioner, they would then need to make sure that they maybe document it in the health record, but get them in touch with someone who can help them, whether it's the Care Navigator service, or maybe it might be someone in their practice who they know is a voluntary assisted dying practitioner. So that might be another way of doing it too. And so that first request really kicks off the process. Then the person who accepts the first request becomes their coordinating practitioner. They would then do the first assessment for eligibility. This is probably the longest consult of the lot, although the consulting one would be very similar as well. If they meet eligibility criteria, they then progress to that second consulting assessment, that independent assessment. If the voluntary assisted dying practitioner doesn't know anyone who could do that, they'll just ring the Care Navigator service and they'll sort that out. Particularly if they're a nurse practitioner and they need to get a doctor and they don't know anyone who can do it, they would need to do that. And so then after that consulting assessment is done, they make that written declaration. That's that second request that's in writing. And then they can make their final request. It seems a bit strange that it's done straight away, but they just say it again out loud. And this is really just to make sure that person, that's really voluntary, and that there's no coercion, and the practitioner can feel reassured that this is happening with all the right intentions and no exploitation. So that final assessment is then done. We know that the eligibility criteria has been met, but we need to just ensure that it's still voluntary, there's no coercion, and that there is full medical decision-making in relation to voluntary assisted dying. The person knows exactly what's going on. So at that point, there's an administration decision. In truth, this is probably going to be talked about way before this, but this is when the physical administration decision is made in the process and the paperwork, because this is really about how is the person going to have their substance. And so self-administration can be either oral or via an enteral access device, so a feeding tube. But the person must take it independently and without assistant. They also must have a contact person. Now, this contact person has requirements under the law, and they have a lot of education, and there's a lot of discussion about that role. And one of their main roles is that they're responsible for the substance if the person was to die prior to having it, or once the person has died after having it, getting it back, everything back to the voluntary assisted dying pharmacy within 14 days, or they could ask the pharmacy to come get it from them, but they're responsible for that. So practitioner administration also is an approved, is for the substance can be oral. So let's say the person can't pick up the cup or put it to their lips and drink it. So that would be practitioner, because they'd have to help. Or if the person needed to have help pushing in the syringe into their enteral feeding device, that would be practitioner administrated. Or if they were giving an IV substance. So the administrating practitioner has have full responsibility for the substance. So you can see the difference a bit more on this slide. So the self-administration or self-administered, they can only have that help going, like someone going to get it from their box and helping mix it as well. But they have to physically drink it or take it, and they can do it within their own time frame. So this is one with much more autonomous. They don't have to rely on a health practitioner and trying to work out, I really want to die on a Sunday afternoon because my family's all going to be here, and the practitioner's like, well, I've got kids' sport, so I can't come till Monday. So, those sorts of things, because there's logistics of trying to organize everyone. And so that there's a bit more autonomy there. But there's also going to be clinical requirements that are going to limit certain people from having self-administration, such as gut motility, or again, back to them being able, whether they can hold the cup themselves. And it's all down to personal preference as well. So there are very strict storage requirements. And what is very important to mention in all of this is that every single part of this process must happen in the ACT. So if someone wants to take a voluntary assisted dying substance and die at their coast house, they need to do a New South Wales process. The substance can't leave the borders of the ACT. If they did, they would no longer be under the protections of our ACT Act, and they would start coming into some issues with the New South Wales legislations, different legislations. So that's really important to know. So that's why I'm saying that people will be making these decisions early on, because if you're having a conversation with your coordinating practitioner, you'd want to know where the person wants to be for their end of life, where they want to be to die, before you got really into the nitty-gritty of the process. Because if they actually did want to die at their sister-in-law's place in Jerrabomba, then they would have to do a New South Wales process. So once that decision's made, the coordinating practitioner does the prescription in hard copy, takes it to the pharmacy service in hard copy. So this is back to the which seems so strange when we were very digital now, but this is all back in hard copy. And the substance is supplied. If it's self-administration, the pharmacy service will talk to the person and the coordinating practitioner about when they're looking at using the substance. We don't want them to have it for weeks and weeks and weeks if we can avoid it, but it also is their right to have it for weeks and weeks and weeks if they want to. But they will aim to take it out to them soon when they're planning to use the substance. And they will go through a lot of education with, they'll take someone from the Care Navigator service with them and go through a lot of education about how to store the substance, how to take the substance, and all the things that they need to know, and all the little bits and pieces for the person and for their contact person. If it's practitioner administrated, the prescription would sit with the pharmacy until it was that agreed time for the practitioner to go to the pharmacy, pick it up, take it to the person, do the administration, and then they die on that day, and then they take it all back to the pharmacy. So this is what the little box looks like for the oral, when we've got the oral substance. So that's a lockable box, and the key is stored separately with the person. And that's just a little briefcase that sort of has all the other things for the practitioner administration. So like we said, with the self-administering, they can do it at any time of their choosing. They don't have to have a specific time frame, but they really are encouraged to talk to their coordinating practitioner, because they're going to be, like, we've got to think about what happens to them after they die, like where they're going to be, who's going to be responsible for them, all those sorts of things. And so we're going to really encourage people not to do this kind of thing on their own, and to have all the plans in place that they can, because this is a planned death. And so the least amount of like scraping things together as we're going would be great, and planning as much as possible, and really having these great conversations about end of life and improving death literacy as a whole. So with the practitioner administrator, it does have to be witnessed, and that just needs to be by someone who is able to take on that role, who is over 18. It is very likely that and this is probably the main way that this is going to happen, that a practitioner would go with someone from the Care Navigator service or with another practitioner, so that there's two people, not just the one anyway. So after death, it's exactly the same as any other death, in as much as the medical certificate cause of death needs to be completed within 48 hours. Just to be really clear about this, the cause of death that will be listed on the medical certificate or the MCCD will be what the person became eligible for under the voluntary assisted dying scheme. The manner of death, which is voluntary assisted dying, will be indicated as that by the person, the practitioner doing the MCCD, but this will not be communicated to the family. So when a next of kin gets the official death certificate, it will only say what the cause of death is, not how they died. We've just been launched today. The births, deaths and marriages have got an online death certificate that they're phasing in, and that's for starting with voluntary assisted dying practitioners, medical practitioners at the moment. There is legislation that's sitting that will be in front of the Legislative Assembly in December of this year to allow nurse practitioners to do the MCCD as well. There just has to be some changes in 3 of our ACT acts. And that's likely to come in mid next year. And so if it's a nurse practitioner or a nurse practitioner or a registered nurse or a medical practitioner who doesn't know the person, such as maybe it might be someone who's been deputised by CARMS or something like that, they would do a verification of death. And so, so if there is an administration happening in a home by a registered nurse, they would be able to do a verification of death, and so the funeral directors can come and take the body. And that we've been really robustly engaged with our funeral director colleagues in the ACT around all of this as well, along with births, deaths and marriages and the coroner and ACT policing. So lots of work has gone into developing, hopefully, an easy and less burdensome administration after death. And so, like we said before, the any of the remaining or unused substance, or just any of the things that come with the voluntary assisted dying kit, just all go back in there and straight to the pharmacy. And so the coordinating practitioner or the administrating practitioner has responsibility for that. An administrating practitioner, and if it's a self-administration, it'll be the contact person. So that is a little QR code that just talks about that. If anyone was interested, I can send that to them about becoming an authorised practitioner. Like I said, we do have 29 authorised practitioners. We've got a couple more coming into training next month. And yeah, so there's a lot happening in this space. We also have a lot of information on our website. There's ongoing education in the community for community members, but also NGOs and other groups, as well as practitioners and health professionals. And so there's a lot of resources that we have on our website that we can share, but we also have our email there. And of course, the Voluntary Assisted Dying Care Navigator service number. And that QR code there, if it's still working, I hope it's still working. I haven't checked it today. It likes to disappear, is for our newsletter. And so that just keeps everyone up to date as well with what's going on. And that is really it. I've just burled through that. And so I'll stop sharing now somehow. And so I'm really happy to take questions if anyone would like to pepper me with questions. Hope I haven't bored you all to sleep out there.
Thanks, Kate. Thanks very much. So you participants, you're welcome to write in the Q&A questions that you have for Kate. So, Kate, while we're waiting for questions, thanks, Kate, very useful information. Will you be sharing these slides? Very informative. Yep, we can send those out. Thank you. Very informative.
I'll just point you all to also the general. So for anyone who's online who's a health professional, there is general awareness training that's on our website. Now that you could either just flick through the PowerPoint, or you can watch me doing a presentation again, which I'm sure you probably don't want to. But so you could, which goes for about, I think the whole presentation goes for about 35 minutes, or flick through the PDF of the PowerPoint, which is really helpful going through this again. It's a little bit more generalized, but it should also bring some of this stuff home.
Where is that, Kate? Is that at the act.gov website?
Yes. Yep. Yeah, it is indeed.
Thank you.
Yeah, general awareness training.
So a question from Estella: do you see a role for end-of-life doulas to support voluntary assisted dying clients and families?
Yeah, this is a really interesting question. I met some like, obviously end of life doulas have become a little bit more common in the palliative care setting, end of life setting, in the ACT, and I met quite a few who were looking at that pathway, and some who had done the Certificate 3 in Tasmania for end of life doulas. I think it was in Tasmania, maybe in Queensland, and they were really interested in this as well, and what they may be able to bring. And I think that it would be a really great thing to have that involvement, because it's a strange sort of time, but it's just I think we don't have a very good idea, those of us in the palliative care sector, end of life sector, health professionals as a whole aren't really very clear about what end of life what doulas could bring. And so I think we need to explore this a little bit more. And I think it's a body of work that compassionate communities are taking up from an organisational point of view across like Commonwealth, across Australia, because that intersection is really a bit unclear. And so I see that there would be a role, but I'm just not sure what exactly that would be. But at the same time, if it brings someone more peace and care and compassion at end of life, then bring it on. The more support that's out there for people that's given by community members and these other roles, then I think that is a really beautiful thing.
Yeah, thanks, Kate. And it would be interesting to discuss this with other states and jurisdictions and who've had voluntary assisted dying for some time now, what the role of end-of-life doulas have been in those other jurisdictions. Might be interesting. Yeah.
I think now we've got that certificate 3 that's happening. That is it's sort of changed a little bit of the perspective of it, because it's not feeling as like there's a bit more of understanding of what that might be for others, and there's a bit more of a level playing field. And so I think that we're in a better place to start that conversation.
Yeah, great, thank you. From Julie Blackburn, will you be offering specific training for aged care providers?
Oh, Julie, we've done heaps. We've done heaps, but maybe we haven't got to all of them. But we've certainly engaged with every single aged care provider in the ACT that I'm aware of, and provided facility guidance on their policies. We're actually going to do another online, and we've only talked about this the last 2 days, another online sort of supporting implementation of the facilities policies next week. Or no, actually not next week. I think it's going to be the 20th. We haven't settled on a date yet, but it's most likely going to be the 20th, and we're going to invite all the facilities that we've engaged with. But we have had most of the facilities, particularly aged care providers, attend one of our workshops or forums, and we've had face-to-face and online.
Great,
and
thank you.
Separately as well, if you're concerned.
Great, thanks, Kate. From Eleanor Law, regarding assessment of intolerable suffering, is this only physical specific or to the diagnosis and advanced condition?
No, it's not. It's talking about full all physical, psychosocial, existential, spiritual. It gets a little bit harder to look at financial, because I have looked after patients who are having significant financial suffering as well. So I think that's really important. Sorry, Estella, it's a certificate 4. Thank you. That's the end of life doulas. I stand corrected. So I think it's all those aspects of what a person may have as their intolerable suffering. And it is, while physical is very important, it is only a one part of it. And when everything else is difficult and hard, it manifests physically as well. So it's a really holistic approach to what that person's suffering might be, and to really we've done a lot of education for our voluntary assisted dying practitioners, but we're really relying on their expertise and their abilities to work with the person to also ensure that they're getting all their needs met. So that, let's say I go and see someone who has significant amounts of pain, and that they just want voluntary assisted dying, but that's probably because they can't think straight because there is so much pain. Well, to make sure that they have palliative care involved, that they've got really good their GPs involved, that they're able to have good pain management. And then I say, right, well, I'm going to come back to you when we have it, when we get things a little bit more under control, see how you are then. So you don't necessarily just to say, right, you've got intolerable suffering and you can have voluntary assisted dying. It's not just about that. It's about you've got intolerable suffering. Yes, you might be eligible for voluntary assisted dying, but what are we going to do in the meantime to make sure that you're as comfortable as possible? Because a lot of people as well will get voluntary assisted dying substances and never use them, because it's a bit more of an insurance policy to, if everything becomes just way too hard, and it's just there just in case, but they may never need it. And so that's really important too.
Thanks, Kate. And that was going to be my question, is if you could unpack the intersection of voluntary assisted dying and palliative care and what you see that looking like. Is there anything else you would like to add to what you've just discussed?
So if you look at the Go Gently reports, they across Australia, about 80% of people who've had voluntary assisted dying are also involved with palliative care. I would like, personally, professionally, I'd like that to be higher in the ACT, because of my palliative care background, I guess, and just knowing that I want to be able to ensure that my patients have the best possible quality of life, whatever that looks like, whatever their choices, and ensuring as well that if, let's say, we know that people lose capacity at end of life, whether it doesn't matter about neurodegenerative diseases, but just in the sheer end of life journey pathway, that they can lose capacity. And so if they were to lose capacity and then voluntary assisted dying was no longer a pathway for them, they still have they are known to palliative care. They still are able to have their suffering addressed by their palliative care practitioners and clinicians, and that they're not left. It's by no means, like almost like if there's other jurisdictions we've spoken to, patients and particularly their families feel like they've failed them because they no longer can have voluntary assisted dying and that they're suffering. But if they're already embedded in palliative care and they've got that around them, then that won't be quite as harsh a decision, and they could still very much so have a death or an end of life that is free from as much suffering as possible, because we've been doing that in palliative care for a very long time, and we need to make sure that we are still providing all of that together and that this remains an option. Does that answer your question, Roz?
Yep, thank you. Any other questions for Kate or comments?
If anyone's, if you've had an experience of this over the last couple of days as well, like people talking to you about it is quite topical, in as much as, I've had people in the community talking to me about it, friends and, all that sort of thing. It's one of those conversations that keep popping up, which is great because, tick for death literacy, we're having another conversation about it. The more we can talk about not necessarily voluntary assisted dying, but end of life care and getting people used to having these conversations, the better. And helping our community really come to start thinking about, what's that going to look like for me? What's that going to look like for my loved one? Where do I want to be? What's that going to be? So that has been I felt really privileged to work in this area because of that.
Thank you, Kate. Just with that, Eliza, the Cert 4 was mentioned. Is this a certificate for in end-of-life dualist services? Thank you.
I believe so, yes.
Yeah. Another question from me is around learnings from other states and jurisdictions. What are some of the learnings that you've been able to gain from, you said you had really great support from the other jurisdictions where voluntary assisted dying has already been implemented. What are some of the learnings that you've taken from that and implemented already in the process in ACT? And are there some that we need to watch out for that we're not sure how that is going to work?
Yeah. I think the biggest one that I'm really happy with, if I look back, is so we were told by 2 jurisdictions in particular to get your community of practice started before you start services, and no one had done that. None of the other states had done that. And so we took that on board, and like I said, I've had 3 meetings in 6 weeks. And really brought them into the fold, and we've all started talking to each other, and it's really good. And we've got nurses and nurse practitioners and doctors, and so that's fabulous. And GPs who are normally quite isolated in their practice, I guess, and now they've got a really strong like and nurses so it's really that I think that's been really a really positive step that we've learned from our jurisdictions. One of the things that was brought to us, like we do have different criteria with our because it's so progressive. We don't know what's going to happen. We also have a very intelligent Canberra community who are very educated. Also, because this has been in the public domain since 2017, there are people who've been waiting for the ACT to go. And so every time it's happened, more people are sort of waiting. And because of our progressiveness of our legislation and not those known timeframes to death, people who might not be eligible in New South Wales may be looking at those have what their substantial connection to the ACT is. We do feel like we've got a lot more border activity because so many people live in our border areas who access the health services in the ACT. We do feel that we'll be looking at many more residency exemptions. I know in my own practice in palliative care, 30% of my patients are from New South Wales. So that just goes to show how many we could be looking at. So that's been we opened up the general inquiries for the voluntary assisted dying care navigator service. We actually we opened those lines about 3 weeks ago, very quietly. It was a little soft launch. And so we got used to answering the phones, and we had a few inquiries then. That was just sort of just by people who were really interested in finding out some more. So getting started has been a really big one, but I guess also frail aged is one of the things that I have been hearing in the last 6 months, when in particular from other care navigator services and communities of practice in other jurisdictions, they're having more issues with people who are just ringing up and saying, I'm exhausted, I'm done, all my friends have died, I don't want to do this anymore. Like I'm old, I'm frail, nothing's killing me, but I don't know why I'm waking up each morning. And so dealing with those sorts of conversations who don't meet eligibility criteria, but then what's your responsibility as a service to make sure that they're cared for? And so it's really seeing what else we can do within our communities to care. It's highlighting where services aren't being met for people, that voluntary assisted dying isn't the answer, but they may be ringing up to find out more about it.
Yeah, thank you, Kate. I think that was one of my other questions that I had, is around life-limiting illnesses, and what is captured in that definition, and what are the ones around the edge that may not be captured that we thought might be, or vice versa.
Yeah, I think that's a very reasonable question, because there's very clear life-limiting illnesses, but it's really those the ones that are a little bit like, but I think one of the ones that's come up in discussions been particularly around Parkinson's disease, which isn't deemed as a life-limiting illness technically, but it has a lot of secondary issues that cause someone to die. And so when it gets to that progressive and advanced stage where those secondary conditions, like maybe the aspiration pneumonia or the ongoing dysphagia that's causing aspiration, those things may be. But these are all very theoretical, and I'm just sort of
Sure. Thank you. I think for me as a palliative care nurse specialist, the communities of practice of the voluntary assisted dying authorised practitioners is very comforting, because I am thinking that during that time there will be palliative care input into those conversations, and that just happen intuitively, and learnings from one another. So that's really great to hear. I think we've Julie Blackburn, with all the anticipated changes that have come in place this week that relate to aged care, there are lots of conversations for both consumers and healthcare professionals. Really appreciate the different approaches that have been taken to educate us on this and have the discussions.
Yeah, pleasure. And if we, but at the same time, I'm not in the sector. We're not there. So if there is anything that you think we should be coming and talking to your colleagues about, if there's certain meetings that happen every month or whatever it might be, if you think there's a need in your area, reach out. That's what we're here for. We want to make sure that everyone understands what's available and that no one is ever having their access hindered. So please, Julie, and to all the participants tonight, if you have any concerns, I will just put that into the chat again. The voluntary assisted dying email.
Yep, great, thank you. And also it's very accessible on act.gov website, and also it would be ACT Health website as well.
Yep.
Thank you, Kate. So if you Googled voluntary assisted, at the very least Googled voluntary assisted dying in ACT, I'm sure that will lead you to a contact person. Also, there is Health Pathways. Don't forget Health Pathways that CHN oversee with Coordinaire. So you can jump onto Health Pathways, and if you pop in there voluntary assisted dying, end of life, or palliative care, that will lead you to the various health pathways as well. There are a few tweaks that need to be just finalised for the voluntary assisted dying page, and also the suite of palliative care health pathways are in the process of being updated. So that is a work in progress, but that is another go-to resource as well. Any other questions before we head off for this evening? Will there be access to pre-printed CNS cards?
They are on the website, and before I shut myself down by mistake before when I open something, so I'm hoping that won't happen again. But yes, I can put the link in for those because they are certainly there.
And CNS is Care Navigator Service cards.
Yeah.
Great. All right. Well, thank you, everyone. And thanks for everyone for joining. And a big thank you to Kate for joining us in this incredibly momentous week, and using some of your words and headspace to teach us tonight. And this, again, as a reminder, is the last of 7 End of Life in Primary Care webinar series. If you would like to reach out to myself or Kate, we're more than happy to take any questions or inquiries or comments that you weren't comfortable to write in the chat this evening. I'd also like to give a big thanks to Kunal, who you haven't seen this evening, but he's been working behind the scenes leading up to and planning this webinar series. And so a big thank you to him, who is our education lead at Capital Health Network. These wouldn't be happening if it wasn't for him. So thank you everyone for joining us. Any questions, please reach out. We love your interest in end of life and palliative care. So thank you, and we appreciate you. Have a good evening, and keep an eye out for other Capital Health Network education events. If you haven't already, please subscribe to the CHN newsletter to keep updated. Thanks again, everyone. Good night.